Medurstand Understanding Medicine.
This is Professor Aziz Rehman from Medurstand-Understanding Medicine. And there is a new development in the field of diabetes and kidney disease, and that is the new compound called Finerenone. And this Finerenone is actually a non-steroidal mineralocorticoid receptor antagonist. So this has come as a good news, because many patients with diabetes, they develop kidney disease and ultimately cardiovascular complication. Now, what is the relevance? The relevance of this is that, approximately 40% of people with type 2 diabetes, they develop diabetic kidney disease in the form of microalbuminuria and then progressive decline in GFR, ultimately leading to end-stage kidney disease requiring dialysis. But on the top of that, nearly 50% of the patients, they develop a fatal cardiovascular event. Before they would die of kidney complication, they could develop fatal cardiovascular complications. So this has led to a new concept, metabolic derangement in the form of diabetes, hyperglycemia, dyslipidemia, leading on to kidney involvement and then the cardiovascular component. So this is actually a new concept. We call it cardiovascular kidney metabolic syndrome. So the concept is all three together have to be dealt with so that we can prevent the complication, both kidney complication as well as cardiovascular complication. We had many options earlier also, but the new option is perhaps better. In my presentation, I will show you how. Since this is a complex concept, I have divided my presentation into three parts, and this is the first of the three. In this one, we will discuss physiology and pathophysiology of renin-angiotensin-aldosterone system. Because without understanding the basics, you will not be able to understand the more complex concepts. In section 2, the next video, I will present clinical research data on this new sort non-steroidal mineralocorticoid receptor antagonist. And in the third section, we will discuss recommendation by international bodies and what do they say if the drug is recommended or not. In fact, I will then have another short video where I will discuss some FAQs of regarding Finerenone so that your concept is clear. So this is actually 4-part presentation. This is the first one, and let's discuss the physiology and pathophysiology of renin-angiotensin-aldosterone system. This is a unique system which almost many organs, they play a role, kidneys, lungs, liver, and adrenals, vessels. So I think it's a very complex and very complex concept. This is a life savior. Renin-angiotensin-aldosterone system is a life savior under acute condition when there is hypovolemia, when there is hypotension, when there is reduced cardiac output, when there is shock. So this is actually a life savior. And what is this? So suppose there is hypovolemia or hyponatremia or hypotension, kidney will sense it as ischemia, and it will produce renin. Renin is a hormone which is produced by the kidneys, and it will be produced in large quantities in this case. So renin will split angiotensinogen into angiotensin 1. Angiotensinogen is produced by the liver in a constant quantity, but itself is a metabolically inactive compound. It is only a substrate to angiotensin 1. So depending upon your hemodynamic state, a certain amount of renin will be produced, and that will convert the required amount into the angiotensin 1. Angiotensin 1 has got certain effects, but it is not very potent. It is further converted into angiotensin 2 by an enzyme called angiotensin converting enzyme, and this is situated in the lungs but elsewhere also. So angiotensin 2 is produced in this situation, and this causes two great things. One is it immediately causes vasoconstriction. So your low blood pressure is raised. So that is the number one emergency measure in such situation. Blood pressure is stopped from falling and a shock may be prevented. But another fact which is more durable, angiotensin 2 will stimulate your adrenal cortex and will produce aldosterone and also cortisol, but I think in our discussion aldosterone is more important. Aldosterone is mineralocorticoid receptor hormone agonist, and this what it does, it prevents leakage of sodium chloride into urine. It actually promotes reabsorption of sodium and chloride and brings it back to the blood. It also brings back water to restore hypovolemia and hypotension. And it also stimulates excretion of potassium because potassium is usually in excess in our body. So potassium is excreted. So when there is stimulated RAAS, this mechanism will also be stimulated. Let's go into some more detail. And this is the structure, kidney structure. This is the renal tubular, and this yellow fluid is actually urine. It is a excretion from the glomerulus and it's going down into the tubule, and this is the tubular cell, kidney in the nephron tubular cell, and this is the capillary. So you can see there's a very complex mechanism, but what it does is it reabsorbs sodium from the urine and then brings it back all the way to the blood. So hyponatremia is prevented, and once the sodium comes back, water also follows it, so hypovolemia and hypotension and shock is prevented. And on the other hand, this potassium, which is produced by the cells, usually in excessive quantities, this potassium is excreted into the urine. So you can well imagine when we will use mineralocorticoid receptor antagonist, now this mechanism will be opposed. So there is a risk of hyperkalemia because the antagonist will stop potassium being excreted. So that would be actually taken as a side effect, and sodium will be absorbed in lesser quantities because we don't want sodium in certain quantities and we want it to go to the urine and less to be reabsorbed. So this is the pathophysiology at tubular level. So I have mentioned a very good and the positive side of RAAS, but RAAS is actually could be harmful also. So this is the harmful effect of chronically activated RAAS. In many conditions, this RAAS is chronically activated, like in hypertension and in chronic kidney disease, in chronic liver disease, in cardiac failure. In all these conditions, this RAAS is chronically elevated, and we have learned that it can have many damaging effects. In acute stage, it was a lifesaver. In the chronic phase, when it is stimulated and unregulated, it can do many harms. Now, this is a long list of harms. For example, it can cause hypertension. It may cause left ventricular remodeling and hypertrophy, and it could cause left ventricular failure, both types, diastolic dysfunction or the systolic dysfunction, and this endothelial dysfunction, promotion of atherosclerosis and renal damage, proteinuria and fibrofluid retention, then electrolyte imbalance, then insulin resistance. Insulin resistance is very atherogenic, so that would cause many problems. Then increased sympathetic activity, which would increase heart rate and will cause vasoconstriction, may cause many issues. Then oxidative stress, and this oxidative stress is very bad because it has got damaging effect on our cells, all vital cells. Then inflammation would lead to fibrosis, both in kidneys as well as in heart and many other organs. So you can well imagine activated RAAS has got so many damaging effects. And RAAS has got two components. One is elevated cortisol, the other one is elevated aldosterone, and our discussion is basically focused on elevated aldosterone. Now, this is the pathophysiology underlying heart failure and chronic kidney disease in patients with type 2 diabetes. Now, of course, kidney can be affected in type 1 diabetes also, but we are talking about type 2 diabetes. As I said, three components of CKM: cardiovascular component and renal component and metabolic component. Now, we will examine all three one by one. First of all, the metabolic component, of course, there is primarily hyperglycemia, but there is hypertriglyceridemia also, and there is insulin resistance also, there is hyperglucogonemia also. So these three things, four things. And then heart component, in heart there could be dilated cardiomyopathy. Why? Because of oxidative stress and inflammation and fibrosis, and hypertension and the myocardial ischemia because of accelerated atherosclerosis, activation of RAAS and sympathetic nervous system. This would lead to left ventricle compliance issues. Left ventricle will become stiff and will have developed diastolic dysfunction, which is one type of heart failure, and it will be increased fibrosis, endothelial dysfunction, and then the vascular disease. All these would lead to various problems, ultimately leading to heart failure. So heart failure is a relatively common complication of type 2 diabetes developed through this mechanism: hypertrophy, fibrosis, diastolic dysfunction, systolic dysfunction, and endothelial dysfunctions. All these could lead to heart failure. Sometimes patient develop a manifestation of ischemic heart disease like myocardial infarction, but many times even without myocardial infarction, without obvious macrovascular disease, one can develop heart failure due to microvascular involvement. Let's take the kidney part. There is hyperglycemia in kidneys, and this hyperglycemia will lead to hyperfiltration, and hyperfiltration would ensure excretion of certain toxic substances and glucose in this case, but it is in itself a damage to the glomerular. Could cause hypertension, activation of RAAS, hypertriglyceridemia, and insulin resistance. Then there may be gradually progressive renal insufficiency, and for many years, maybe up to a decade, there may be progressive renal damage and there may not be any symptoms at all. Patient, maybe when you do the test, you will find albuminuria or you will find elevated creatinine or reduced GFR, but patient may not have any symptom. And there is fibrosis in the kidneys, there is increased sodium and water retention by the activated RAAS, and there is dysregulated kidney function, ultimately leading to CKD. But it's not just the CKD which bothers us. It is actually the development of inflammation and then myocardial infarction, cardiovascular syndrome. So this trio, metabolic abnormalities, kidney disease, and heart disease, they lead to this trio of complication which grossly limit the life of these patients and affect the quality of life. So we will try to manage this, and we will try to slow down or reduce the progression of this so-called cardiometabolic kidney syndrome. So these are certain definitions, and like other diseases, this CKM also has certain stages. CKM 0 is somebody who is just normal, and very unfortunately it is becoming very rare and rare. Finding a person who has no metabolic abnormalities is becoming rare. This is individuals with normal BMI, which should be less than 25, and in our country it should be less than 23. Waist circumference, which should be less than 40 inches, but in our country less than 35 because we are Asians. Normal glucose, which should be less than 100. BP should be normal, less than 120/80. Lipid should be normal, like cholesterol should be less than 200, and LDL should be less than 130. And no evidence of subclinical or clinical atherosclerotic cardiovascular disease. That will constitute CKM 0. CKM 1 is somebody who has visceral obesity, and this is the only requirement. So patient's waist circumference is increased, and patient has got visceral obesity, which can be obvious even without measurement, or which can be tested in many other ways also, like CT scan, DEXA scan, but I think simple is waist measurement. But these individuals, they have increased BMI but no other known or detectable kidney or cardiovascular disease. In CKM stage 2, there is metabolic risk factor added. So a patient has got visceral obesity. I think please let me emphasize that at the root of this all CKM syndrome is visceral obesity. So in this situation, there is visceral obesity. In this visceral obesity, there are some added metabolic complications, like there is hypertriglyceridemia, more than 135, hypertension, and metabolic syndrome. That means there may be fatty liver. There may be accumulation of fat in the liver detected on ultrasound, or abnormal ALT. So this is the problem. Or there may be some manifestation of albuminuria. So further, the CKM3, there is visceral obesity and metabolic derangement, but then there is some subclinical CVD or CKM. So patient has got the same patient actually progressing to further stages. Patient has subclinical cardiovascular or renal involvement. Patient may have heart failure. It is not giving him any symptoms as yet. But if you do echocardiography, there is reduced ejection fraction or there is diastolic dysfunction. Similarly, if you do kidney test, patient may have microalbuminuria, or patient, if you do creatinine may be little elevated. So there is involvement of organs, but it is still subclinical. And it is very likely that patient is not bothered about these till this level, because everything is subclinical and patient is not having any symptom. Only in CKM4 patient has symptoms, like symptoms of heart failure, symptoms of ischemic heart disease, symptoms of atrial fibrillation, symptoms of kidney failure. So there would be symptoms. So please don't wait for the last stage. Take action early as possible. Now in the next slide, I will show you how these things progress to the next level. So these are the same stages. This is CKM0, stage 1, stage 2, stage 3, and stage 4. So this is actually stage 0. We should all follow these essential 8s of life, and there is a separate lecture for this. Basically, sensible eating from the vegetable source, restricted eating, not too much, and doing exercise, abstinence from smoking, and all this stuff is to be done here. Then in stage 1, you have visceral obesity, then you have metabolic complication, subclinical disease, and then the clinical disease. This is how it progresses. And very unfortunately, when these things are progressing at any time, maybe before you would develop kidney related complication, you might have a major cardiovascular event in the form of sudden death, non-fatal myocardial infarction, angina, or heart failure. So we have to intervene in this progression so that patient can have extra life without these complications. So how many RAAS blockers we have available? There are many. ACE inhibitors, we have ARBs, we have direct renin inhibitors. There are many examples of ACE inhibitors and ARBs. But renin inhibitors, they became available, but they weren't found very useful. They disappeared. Mineralocorticoid receptor antagonists, we have many of them available, at least 2, but now there is a third one. Next of the discussion will be focused on this one. Then beta blockers also indirectly, by reducing sympathetic activity, they also slow down RAAS. And then we have angiotensin-neprilysin inhibitors, which is a combination. So all these tools are available and we are using, but they are still not adequate because patients still develop further complications. And now we have another one. I think that is why I am so excited. So the two types of mineralocorticoid receptor antagonists, the steroidal one, the conventional one, we have spironolactone and we have eplerenone. Spironolactone is non-selective. That means it will block mRA, mineralocorticoid receptors, as well as androgen receptors. And because of that, it would lead to some sex-related complication. But it is potent drug, potent blood pressure lowering effect and potent mineralocorticoid receptor antagonism. Then we have eplerenone, which is less potent but selective. It would have much less effect on androgens. But now we have non-steroidal. These are steroidal in structure, but this is non-steroidal. It has got function of mineralocorticoid receptor antagonism, but chemically it is different. It is not a steroidal structure. Finerenone. It is the only one so far in this class. Now let me compare these two in more detail in the next slide. So we will compare non-steroidal mineralocorticoid receptor antagonists versus steroidal mineralocorticoid receptor antagonists regarding these features: molecule, receptor selectivity and effect, effect on inflammation and fibrosis, other effects and side effects. So non-steroidal like finerenone, potent and selective. Now this combination is rare, something potent as well as selective. So that is the unique feature of this new non-steroidal mineralocorticoid receptor antagonist. Whereas steroidals are, spironolactone is potent but non-selective. Eplerenone is otherwise, it is not potent but selective. Then it has got strong inhibition of inflammation and fibrosis. You see, this is the one. And this is actually the main the feature of this new salt, which makes it very, very useful. Because it is the inflammation and fibrosis which leads to progressive disease. Now, if we can block, if we can slow down inflammation and fibrosis, maybe we can prevent kidney disease going to the next stage. Then greater cardiorenal protection but less BP reduction. Now this drug, this finerenone, had goes greater cardiorenal protection through its antioxidative, anti-inflammatory, anti-fibrotic action, but it has got less blood pressure lowering effect. So when it comes to resistant hypertension, we will still be using spironolactone. Then low risk of hyperkalemia. Hyperkalemia is possible with finerenone also. After all, it is a MRA blocker. MRA, it is a mineralocorticoid receptor antagonist. So, but gynecomastia and erectile dysfunction and lactorrhea and galactorrhea and erectile dysfunction and menstrual abnormality will be less common. Now, this point I've already highlighted that spironolactone has got an edge when it comes to blood pressure lowering effect in people with stage 4 hypertension. When people are not under control and we want to add an MRA, we will still consider spironolactone in that situation. Although finerenone also has good blood pressure lowering effect in full dose, but it is definitely much less than spironolactone. So with that, I like to conclude my first part. This was basically the introduction to RAAS and various MRAs and their comparison. And the concept of CKM was highlighted, and I hope you have understood it. And please join me in my next 2 videos which will complete the module. Thank you very much. This has been Professor Aziz Rehman from Medurstand-Understanding Medicine. You can scan this or you can just type this word anywhere on the internet. You will be right in my channel. Thank you.